Hey guys, John Adams, the Rehab and Documentation Guru. It's been a little while since I've shared a piece of documentation of my own with you. I have been absolutely slammed with starts of care, evaluations, recertifications, and reassessments this last few days, and it's just going to continue. It seems like everybody's due right before Christmas, and then I've got an orthopedist in our area who's decided to do everybody right before Christmas. I don't know what's going on. He must need a new yacht for Christmas or something. But I thought I would share with you a recertification note. And this is one I'm going to send to in this case, the PA that is going to be recertifying this particular patient. Just to give you a little bit of background on this particular patient, he is elderly. He would be on the upper scale of elderly, but generally a very fit guy, very active guy, and then he developed cancer. And he's being treated with chemo rather effectively, and he's doing quite well, but he does have some peripheral neuropathy related to it. He is hard of hearing, does wear hearing aids, and I suspect because of that, it's likely nerve damage, impairment. Why? Because he's got some vestibular deficiencies that I've seen. But when you recertify somebody and you're telling Medicare, look, you got to pay for another episode of care, we need justification. So what I'm going to do is I'm going to read this for you, and as I'm going through it, I'm going to break it down. I just posit this as an example of what I believe to be good documentation. You may differ. You may have some suggestions. If you have any commentary, please go ahead and mention it. However, without sharing any patient specifics to violate HIPAA, here we go. So this is addressed to the PA. Your patient was seen for a home health recertification today. You may be receiving the following for approval. You will be receiving. Number 1, recertification orders. On them, I have included the need to receive in-home interventions, in part due to his high risk for COVID-19, due to immunosuppression for his cancer treatment, in addition to other criteria for homebound status that he has. By the way, sorry about the rain. It is wintry mix around here. I'm thankful I'm not further north because they're getting snow mix, and probably 10 to 15 minutes north, they're probably getting pure snow. I'm sure it's a mess. But anyway, I'm fortunately a little bit more south. So with that said, let me stop there for a second. Right now, Medicare is giving certain provisions related to COVID-19 risk exposure that allows Part A benefits to be used for in-home care. But the doctor must sign off that the risk is related to COVID, and that in part makes it impossible for them to go outside the home to receive therapy. Now, this guy has other criteria that I believe that make it difficult for him to get out on a regular basis, thus fulfilling the homebound criteria, but his immunosuppression is definitely a big one. So, my computer has an issue with wanting to sign me out, so I'm going to get through this before that happens. Okay, number 2, ongoing disciplines. So we're going to continue not only PT. My report here is to mainly focus on PT. OT will be performing a separate reassessment. So now I'm going to focus on me. His status is significantly improved with the following changes noted in the last month. So since my last reassessment, 30 days ago roughly, his timed up and go has improved from 22.5 seconds to 18.5 seconds. This is statistically significant and demonstrates progress in strength, balance, initiation of movement, and gait speed. It is still greater than 1 standard deviation from low fall risk, however, and will remain a focus of treatment. 1 standard deviation for the tug is roughly 4 seconds, and 4.5 seconds, 14 seconds is generally considered a cutoff score for high fall risk. 2, his 30-second chair rise modified with the use of arms. So I do allow for measurements with a modified 30-second chair rise. Maybe it's not entirely statistically accurate, but it still gives good evidence of progress. Modified with the use of arms has improved from 4 reps to 10 reps. This is 3 standard deviations of improvement. So 2 points is a minimal detectable change, yeah, outside the standard deviation that you need to show improvement. So going on. So is very significant. However, he remains unable to initiate sit to stand without use of arms, so his lower extremity weakness remains significant. Normative for an 85-year-old male living independently would be greater than or equal to 8 without the use of arms, so he remains deficient in this area. So not only am I pointing out the value I've added to Medicare, but I've got more data to support that I need to keep seeing him. His Tenetti POMA improved from 15 to 16 out of 28. This is not statistically significant. Key areas of remaining concern include his raw balance score, so that's where he was mostly deficient, with lack of sufficient fast and strong reaction to balance perturbations. This will be addressed further in future treatments. His main issue is definitely his peripheral neuropathy, so I'm going to be addressing this more specifically, especially his ability to compensate quickly for balance. Continuing, I assessed his 2-minute walk distance today, so I'd not done this before, which looks at the overall fitness of the individual. His distance of 67 meters is well below general population age normative of 140 to 150 meter range. That's rough estimate based on his age range and the fact that he doesn't necessarily have a diagnosis of like pulmonary disease or cardiac disease that limits him. Given a minimal detectable change of 12 meters, this places the patient approximately 6 standard deviations below normative. His rating of moderate breathlessness after completion of this task correlates that this test is an accurate assessment of his cardiopulmonary functioning and demonstrates impairment. We will be addressing these items in our updated care plan. Your timely signature will ensure continuity of care. Please let me know if you have any questions. Thank you. So anyway, we want to summarize why are we going beyond the current certification, justifying one, we've rehabilitated this guy. It's clear he's made excellent progress, but he's still not where he should be, even according to age normative data. So I've got the data to back up that we've been valuable so far and it's worth paying for us ongoingly. Part of what justifies ongoing payment is the fact that I've made such excellent progress. Forget section GG on the recertification OASIS, which has shown definite progress. I have better data with my standardized tests, and I've talked about the deficiencies of section GG in the past, and Medicare's tools are not sufficient to really capture adequately the progress that we've made. So you better back it up with some really solid objective data, which I've done that here. But if you have any points or suggestions, feel free to bring it up. Anyway, that's all I've got for today. I hope you're having a great day. Better than my weather, hopefully. Take care and God bless.